Okay, well, good evening, everyone online. I would like to introduce myself. My name is Meredith, and I am an education coordinator here at the Western New South Wales Primary Health Network based in Bathurst. Also on screen, you'll see my colleague, Erin Hollier. Welcome to this GP Masterclass with Dr. Paul Ginty, who I will introduce shortly and who will be conducting this presentation. Before we begin, I would like to acknowledge that we're meeting tonight on the lands of many Aboriginal nations across Western New South Wales. As I join you in Bathurst, I want to pay my respects to the Wiradjuri people whose connection to this land stretches back thousands of years. Western New South Wales Primary Health Network respectfully acknowledges Aboriginal and Torres Strait Islander peoples and their tradition as the traditional custodians of the land, and affirms the commitment to building relationships with respect and creating opportunities with all Aboriginal peoples in our region. I pay my respect to elders past, present, and emerging, and extend a warm welcome to all First Nations people who may be in this meeting tonight. I would now like to introduce you to our presenter for this evening. Dr. Paul Ginty is an adult cardiologist with an interest in non-invasive cardiac imaging. He completed his cardiology advanced training at Westmead Hospital and is currently enrolled in a PhD at the University of Sydney. Paul facilitates stress test, stress echo, resting echo, and Holter reporting and cardiology consultation at We Care Health in Bathurst. Before we begin, I would like to do a little bit of housekeeping. The presentation will be approximately 90 minutes, comprising a didactic presentation and a case study, with time for questions and discussion at the end. As we may not have time for all questions to be addressed, please pop them in the chat and we will endeavour to follow up. This session is being recorded. We ask that your webcam is on if possible for connectedness, and mic is on mute unless you are participating in the case at the end. At the end of the presentation, there will be a very short evaluation form for you to access via QR code and a link in the chat. If you could please scan that QR code to answer that very short evaluation, it's very helpful for us in planning future sessions. We also have an optional post-measuring outcomes activity for you to complete if you wish to claim an additional 1 hour measuring outcomes CPD within the next 30 days of this event. The form will be also available via QR code or a link in the chat box as well. Everyone will receive a certificate of attendance within 72 hours post-event. For GPs, CPD will be reported for you. Please ensure that you update your Zoom name so that we know who has joined the session. I would now like to hand over and warmly welcome Dr. Ginty for his presentation. Thank you.
Thanks, Meredith. Great. Okay. Well, thanks, everyone. Thanks for that introduction. The topic today is a bit of an update on heart failure. So I've tried to keep things reasonably sort of practical and clinically based. I think heart failure is a topic that can get quite dry, but also it's one of the more common things we see. So feel free to pop questions in there. We will have time at the end. I'll try not to fill the whole 90 minutes with me talking because that's a lot of me talking. But yeah, there's a short case at the end, but any time in between we can stop and chat about things. Okay, so the learning outcomes for today, just checking the chat. Okay. Talking a bit about the heart failure in general and the different phenotypes. A bit of an update about therapeutic options, which has probably been where the majority of the change in the last 5 years or so have been. And then a little bit about some particular situations. There won't be enough time to go through everything in detail. Obviously, it's a pretty big topic. But if anyone has anything particular, questions or anything else would like to talk at the end, let me know. So heart failure, it's not really a diagnosis. It's a clinical syndrome. And sorry, I'm just going to, if I can hide these, that's better. It's obviously not a single disease. It's a clinical syndrome that's made up of classic symptoms, dyspnea, fatigue, clinical signs basically related to congestion, and then some sort of structural abnormality, particularly on an echo that suggests that it's from a cardiac cause. So that might be reduced ejection fraction, or it might be valvular disease or significant diastolic dysfunction. And really, technically, for it to be heart failure, we should have one of all three categories. But obviously, within that, there's a whole list of things that can cause that clinical syndrome. Generally, as we all know, we categorize this very broadly by ejection fraction, historically just between reduced ejection fraction or HFrEF and HFpEF, preserved ejection fraction. I'll go into that a little bit. That's changed a bit over the years, the definitions and the cut points we use, but there's some good reasons for that categorization. It's different etiologies will fall into different groups. Prognosis and management is very different, but obviously there's overlap, and whatever cutoffs we use are somewhat arbitrary when things really are a spectrum. So as I mentioned, ejection fraction is one way of classifying heart failure, and that does correlate with the etiology. For example, an ischemic cardiomyopathy is more likely to cause HFrEF, as opposed to hypertensive heart disease, or infiltrative cardiomyopathy is going to cause more of a hypertrophic, thick-walled left ventricle with diastolic dysfunction. Probably all also familiar with symptom classification, so NYHA class. That's obviously quite prognostic, but it's also dynamic. And depending on someone's fluid status or the clinical picture, that can change. There are other ways. There's clinical stages, which some of the guidelines use, which classify heart failure from stage A all the way through stage D. That's somewhat less used clinically, particularly stage A, which is sort of things like pre-heart failure, which is people that don't really even have heart failure, they're just at risk. So that's not something we talk so much about clinically. And then obviously etiology is important, and figuring out the etiology is often quite important beyond just sorting into HFrEF and HFpEF. And really today I'm talking about chronic heart failure. Acute heart failure is a bit of a different beast. Obviously, we often see people with acute decompensations of their heart failure, but usually that's an acute on chronic thing or a semi-acute thing. True acute heart failure is less common, obviously. Things like a large myocardial infarction, myocarditis, a stress cardiomyopathy like Takotsubo cardiomyopathy. So acute heart failure where people end up in cardiogenic shock is obviously quite a different thing to the congestive cardiac failure that we generally manage in rooms in the community. So I'll try not to just go bang on and on about guidelines, but in cardiology, there's lots of guidelines. There's lots of big studies with hundreds and thousands of patients. So, and we can get a bit from looking at guidelines and also how the guidelines have changed. So, the most recent Australian guidelines, Australian New Zealand guidelines, are from 2018, and at that time we sorted heart failure into HFrEF and HFpEF based on an ejection fraction of 50. And there's just that note there to make a note of. I'll get my pointer out. You can't just be short of breath with an ejection fraction of 50 because that could be something totally different. That could be COPD. You do need evidence of some sort of cardiac dysfunction on an echo, or evidence of diastolic dysfunction. Usually that's also on an echo. We're not doing right heart caths on people routinely. But now we do have a bit more. We have NT-proBNP, which I'll mention in a bit, which is now something we actually can do with PBS, MBS reimbursement. Talking about HFrEF versus HFpEF, I put this up to show a lot of our trials. It really depends on the trial, what we call HFpEF and HFrEF. So these are all reasonably recent trials. In fact, these are all quite recent landmark trials. And HFrEF can be anything up to 35 or up to 40, even up to 45. And HFpEF can often go down to 45 or even 40. So some of these studies that are big ones showing that SGLT2 inhibitors work in HFpEF, they're including patients down to 40, which in the past we would have called HFrEF. So just pointing this out to say that in particular, this is one of the reasons why ejection fraction of 40 to 50 is a grey area. We're pretty confident in people with EF below 35 and people with EF over 50, but in that middle range, there's less clear evidence, partly because there hasn't really been any dedicated trials. And so knowing what drugs work and are going to help patients is less clear. It also doesn't help that ejection fraction is actually a surprisingly blunt tool, and it's not that repeatable inter-observer on different days and different measures. So the fact that we use it to decide on things like defibrillators and cardiotoxicity is a bit iffy at times, because depending on image quality, you might get ejection fraction of 45 or 38. So we shouldn't fuss too much about a few percentage points. So a problem until recently has been even a definition of heart failure. And so a couple of years ago, kind of the whole world decided to get together with their heart failure societies, and everywhere seems to have a heart failure society. America, Australia, Europe, Japan, Canada, India, China, to try and come up with a definition. And it can get a bit confusing, but basically it's similar to what we've had previously, but you need some sort of symptoms and signs, and you need some sort of objective evidence. So elevated BNP and or some sort of evidence of congestion. And this is the proposed classification with heart failure, which you may have seen. It's not much different, but we're now saying HFrEF is 40 or below, HFpEF is 50 or below, and really 40 to 50 is what we're now calling mildly reduced ejection fraction. And it may be that those patients tend to behave more like HFrEF, but I think really that's a very mixed bag. There might be people in there with ischemic cardiomyopathy, there might be people in there with some form of hypertensive cardiomyopathy. So it's not surprising that it's quite heterogeneous how those patients go. And there's a bit more thought now about patients with improved ejection fraction. And if you have someone where you start a beta blocker and their ejection fraction goes from 38 to 48, how do you treat that patient? Do they stay on their heart failure medications forever if it normalizes? So that's an area of interest as well, the patients with improved ejection fraction or recovered ejection fraction. Yes, I think I've gone to that. So basically, we shouldn't really call someone HFpEF just because they've got ankle swelling. If there's really no other sign of uh, a problem on their echo, then maybe they have just venous insufficiency. So technically, to call something heart failure, we should have some sort of objective cardiac abnormality. I might go through this pretty briefly, but every guideline has some sort of diagnostic algorithm. But the thing they all share is obviously we need to have some sort of suspicion based on exam. All the guidelines pretty strongly advocate for an ECG and an X-ray. In fact, one of the guidelines even says that completely normal ECG makes heart failure very abnormal, very unlikely. So if you've got a plumb normal ECG, that in itself can make things less likely. And then obviously most patients are going to get an echo, and increasingly NT-proBNP can be used particularly as a rule out test, which I'll go into a bit. And then once we've confirmed heart failure, it's really the echo putting us into HFrEF, HFpEF, and that sort of thing. And the management from there is going to be quite different, which I'll go into. So I've put a slide on natriuretic peptide testing, mainly because it's obviously not a brand new thing, but I think in the last 12 months, we now actually do have a rebatable test. It's really for the exclusion of heart failure, and once in 12 months. And the reason for that is that a completely normal BNP makes heart failure pretty unlikely. There's always some caveats to that. Obesity can actually make someone's BNP lower, and there's some evidence that HFpEF is less likely to be so elevated. But really, if you've got someone who's short of breath and their BNP is completely normal, particularly if they're over the age of 50 or 60, where you can see we now have age adjusted cutoffs, it's pretty unlikely that it's a cause of them to have major symptoms. The other way around, not so much. A lot of things can put BNP up, so it's not so good as a rule-in test. But generally, if someone's got a particularly elevated BNP, it does raise flags that it's likely to be from a cardiac cause. The Europeans, I just put this up, it might be a bit tidier than the Australian one, but basically the same deal. They put BNP sort of central, where if it's normal, you go down an unlikely path. If it's abnormal, or if you can always override it. If you suspect it, then you go down further. This is just to show that, like I said, heart failure is not a diagnosis, and it's tiny text there. I didn't blow it up because really, the top few there, coronary artery disease, hypertension, valve disease, are going to be the vast majority of things, and things down here like, nutritional deficiency and glycogen storage disease are far less common. But when you diagnose someone with heart failure, you're really trying to also get to an idea of what's causing it, because that can guide things as well. That's reiterating things a bit. So, do they have heart failure? What type is it? And what might the causes be? The causes are going to be quite different in their prognosis. There might be targeted therapies, and in some cases, things like amyloidosis, which I'll talk a little tiny bit about because I'm biased on that. Some of these things are genetic or inherited. So, previously, we haven't done a very good job of doing genetic testing for people with non-ischemic cardiomyopathy. That's changing a bit, and really we should be. We can do reimbursed genetic testing for patients with cardiomyopathies to try and miss fewer patients with inherited causes of that. Moving on a bit to management, it still is largely guided by ejection fraction for general management. But as I mentioned, that middle ground is sort of an area where things are still being sorted out. There's a lot more to talk about in HFrEF because there's a lot more drugs, and I'll go through that in more details. But I've just put this up to show that the European guidelines came out in 2021, and usually guidelines last a while, but 2 years later they decided there's been too many trials that their guidelines were already outdated, so they brought out an update 2 years later, which is pretty quick turnaround. The goals of therapy, I guess this can be said for anything, but in heart failure, it's obviously to improve outcomes, so mortality and hospitalizations. Congestive heart failure has a very high rate of healthcare use and admission to hospital, as we all know. These are very comorbid patients, and a lot of these patients spend half their time in hospital. And obviously to improve symptoms, and some treatments don't have as much evidence for outcomes, but can help symptoms. And management consists obviously of pharmacotherapy, which I'll focus mainly on, also in cardiology devices and ablations, which I haven't really got much on, but if anyone has any questions, so cardiac resynchronization therapy, AF ablation in heart failure is an area that's evolving. And obviously what I haven't put up here is other things like just how useful heart failure clinics can be, community heart failure services, and even things like exercise rehab has got pretty great evidence, as you'd expect, for helping improving symptoms and even outcomes. I won't labor this too much because I think this is not really new anymore, but we used to talk about the 3 pillars of heart failure therapy. We now talk about the 4 pillars because we've added SGLT2 inhibitors. But really, the idea, particularly for HFrEF, is patients should really be on all 4. Loop diuretics, furosemide, are really if they need it for fluid retention, and that's a symptomatic thing. But the 4 above that are all pretty robust reducers of outcomes, and there's pretty good big data, big studies showing that. Like I said, I won't go into a huge amount of this, but these are from cardiology guidelines, so this probably will be familiar for everyone, but particularly in ischemic cardiomyopathy, primary prevention defibrillators are reasonably supported by evidence if the ejection fraction is below 35%. The evidence is a bit less strong in non-ischemic, but that's sort of being revisited as well. So generally, if a patient's young and has a significantly reduced ejection fraction, they will be offered a primary prevention defibrillator. If things improve on medical therapy above 35, they're generally not offered it. And this one here is really if they don't improve symptomatically and they have quite a broad QRS, this is where they'll get cardiac resynchronization therapy, which is CRT, or a bi-V pacemaker. That's kind of a whole topic in itself, but basically it's a particular pacemaker or defibrillator to try and resynchronize a left ventricle that's quite dysynchronous. There's evidence that that can particularly help symptoms in patients that are still short of breath, but really only indicated if the ejection fraction's down, and particularly evidence-based if they've got a broad QRS. Yeah, there's also often comments made in guidelines that we're getting better at starting all these medications, but we're not as good at up titrating to the really big doses. And a lot of these trials were done with pretty big doses of these medications. I sort of try and balance that with most of these trials didn't include anyone over the age of 70 or so. So you see some patients that are in their 80s and they've been put on massive doses of beta blockers and Entresto, and they're not doing very well. So I think we have to be sensible and tailor things to the patient. And you don't really want people's age being higher than their blood pressure, which you sometimes see with these medications. And that's just showing this. I mean, that's a bit small, but and for whatever reason, this American one, they didn't have a lot of the ACE inhibitors we have, but 50 daily of spironolactone, 10 daily of bisoprolol, and sort of the big maximum doses of the ARBs. And again, not all beta blockers are equal when it comes to heart failure. It's generally these, we don't use a lot of long-acting metoprolol, but bisoprolol, carvedilol, and nebivolol have the evidence for heart failure and reducing mortality. moving on beyond beta blockers, again, ARNIs aren't all that new anymore, but this is a reasonably big breakthrough in the last 5 to 10 years. So this combination of a neprilysin inhibitor, neprilysin breaks down the body's natriuretic peptides. So by inhibiting that, you're sort of letting the body do its own thing by reducing aldosterone, reducing systemic vascular resistance, and they obviously have a natriuresis and diuretic effect as per their name. So this drug was developed to have both angiotensin blockers, obviously, which work on what anyway ARBs will do, and so it's sort of by two complementary methods. It's kind of like a souped up ARB, and it has effects similar to that. So the key landmark trial for that, which is a few years ago now, was patients who were reasonably reduced ejection fraction, like I said. So these were people with HFrEF. They actually dropped it as the trial was starting, and they had to have been on an ACE inhibitor and a beta blocker, and they had to be reasonably short of breath, and include NYHA4, which is pretty sick patients. And they decided to compare it to enalapril, which is not a commonly used ACE inhibitor, but it's actually got some of the more evidence behind it compared to other ones. And again, this is reasonably, they really drilled this into us, so we're all familiar with this, but it was pretty impressive. Remember, this is not versus placebo, this is versus an ACE inhibitor. A 20% relative risk reduction in primary endpoint, which was a combination of heart failure or cardiovascular death. But even just cardiovascular death, a pretty hard outcome, 20% reduction. We obviously worry about hyperkalemia and that sort of thing with these drugs. The main differences were people were more likely to be hypotensive, and particularly blood pressure under 90 was more common. It still wasn't super common, but it was more so in the Entresto group. But interestingly, the elevated creatinine and elevated hyperkalemia was actually higher in the high-dose ACE inhibitor group. So when we're worrying about electrolyte side of things, this would suggest that maybe Entresto is not something we worry more as much, or even certainly not more than an ACE inhibitor. But having said that, as I mentioned, particularly in elderly patients or who already don't have a lot of blood pressure to work with, generally hypotension is the main limiting thing. And I sort of try and apply that if people don't tolerate it, they don't tolerate it. There's still a lot of very good evidence behind ACE inhibitors or ARBs, and it's very reasonable to keep patients on that. Now, SGLT2 inhibitors, again, this sort of seems to be they keep finding indications for these drugs. They have strong indications for type 2 diabetes, not type 1, I'm aware of that. CKD, so there's now indications that purely for proteinuric CKD, down to an eGFR of 25. And initially quite strong evidence in HFrEF, and more recently there's been a few trials that have now got a separate PBS indication for HFpEF, and I think now even empagliflozin has a type 2 diabetes indication, regardless of the HbA1c or something sort of just up front. So it's almost like you can start these on everyone now. My lights have just gone off. Okay. And they do seem to be quite well tolerated. In terms of outcomes, particularly in HFpEF, the main benefits really were on reducing hospitalization. So it's a bit controversial whether, in a way, these are acting mainly as a diuretic, but they do seem to, or at least claim to have far more effects than that they actually are improving the myocardium and protecting it. As we know, the reason they work so well is that we reabsorb a whole lot of glucose through the kidneys, and if we can block that, particularly with the SGLT2, which is where 90% is reabsorbed, we can have quite significant glucose excretion, which is why they have their effective glycemic control effects, but also they have a natriuresis and a diuresis as well. And again, I might not spend too long on this, but with all these trials, it's worth thinking about what patients they were in, and that's sort of the key question. So eGFR over 40, they excluded people with blood pressures under 95 and type 1 diabetes, and again, 40%. So that sort of corresponds with our HFrEF, and kind of all these trials are the same, 25 to 20% reduction in their outcomes. And these patients were all already taking the existing 3 pillars. So I think that's something to remember, that these are reasonably impressive results when these people were already on their beta blockers and ACE inhibitors, and probably most were on their MRAs as well. And there's been a lot of trials now and really pooling together the two drugs in HFrEF. They do seem to reduce mortality, cardiovascular mortality, and particularly once you throw in heart failure there. So more and more trials these days seem to be using combined endpoints, which is maybe a bit less of a hard outcome when they can't quite get mortality. They throw in heart failure hospitalizations, but even on its own, mortality was significant, and hospitalization is a significant outcome. So even if we're preventing people going to hospital, that's something. And it didn't really matter if people had diabetes or not, which is reflected in the indications. So they're not really treating the diabetes directly in these patients, they're treating their fluid status and their heart failure. I'll briefly mention vericiguat because it's a drug that we might see a bit more of our patients started on. It's sort of being added as almost a fifth pillar. It's probably nowhere, I shouldn't say that, but it's not as exciting or dramatic results. But do I have much more about it? So it's sort of been on PBS since 2023. Vercuvo is the name for it. And really, the indication is if people have had a decompensation of their heart failure, but they're now euvolemic, they're diuresed. This is a soluble guanylate cyclase stimulator, and it's basically a vasodilator. And in the study, it had a modest reduction primarily in hospitalization. So it's now on PBS, and as I mentioned, the outcomes were primarily, this is a good example. If we look at cardiovascular death, I mean, it's trending, but the p-values are not significant for death. But once you add it with heart failure, it becomes somewhat significant. So when we think about these medications, it's always good to remember that in particular, in a way, the most effective ones are beta blockers and MRAs, and they're the cheap drugs that we've had for a long time. That's also partly because probably all these newer drugs, like SGLT2 inhibitors, the trials were done when people were already on beta blockers. So we don't have a trial of SGLT2 on its own or ARNIs on their own. So that's something that the newer drugs could argue that they've got a bit harder. And it was easy back in the day when we just had beta blockers and ACE inhibitors. But really, if you look at bang for your buck, I think we often overlook spironolactone because it can have issues if people have, you know, borderline kidneys or potassium. But there's really strong evidence for spironolactone, and it's a cheap drug. There is a eplerenone now, which is an option which has less gynecomastia, which can be an issue. Um, it's currently not on PBS for that reason. It's got a funny indication recently where it can be started within 14 days of an MI. Eplerenone can be started as the MRA. So it might be that we get a bit more access to somewhat more selective mineralocorticoid receptor blockers. Hydralazine on nitrates is an interesting one. There's a funny signal that in the American studies in African Americans, it seems to be quite good at reducing mortality, and to the point where the guidelines have class 1 evidence in those groups. But outside of that, it's not really something we use first line at all for heart failure. This is another way of expressing that, just showing that this reasonably recent thing, that once you start adding all these things together, you get really quite impressive hazard ratio reductions. This is all-cause mortality, and you sort of get 70% reduction in death compared to placebo on its own. And you can kind of see that as you chuck more things on there, you get pretty impressive improvements in mortality, which is why this sort of stuff keeps getting hammered into us. All of these things are a little bit, wordy. All the guidelines have their own sort of spreadsheets. They can be helpful to have just to sort of remember. It's still not entirely clear if there's one particular order to do things, which I think is a common question. Do I start an ACE inhibitor? Do I do a beta blocker first? This Australian update recently split people between congested and euvolemic. Are you seeing a patient that's fluid overloaded? In which case, obviously starting diuretics probably is best to leave the beta blocker till they're a bit better. But certainly adding the MRA and even ACE inhibitors have a diuretic effect. So it's sort of all saying the same thing repeatedly. And this includes things like device therapy. I won't belabor things, but we probably underuse ivabradine has reasonably good evidence. If someone still has reduced ejection fraction and their heart rate's not very good on a beta blocker, adding that to slow people down further can help. And there's sort of all these different less common things, but I might just skip through that in the interest of time. Iron deficiency is very common in heart failure. It's probably multifactorial. Also, these are generally quite comorbid patients. Um, it independently predicts a lot of things, even if they're not anemic. So people feel significantly worse. They're more likely to get hospitalized, and mortality is higher. Um, the studies seem to show, well, there was a study of oral iron that didn't seem to show any signal, and it's probably just because it wasn't very effective at replacing iron. So really, it's IV iron. And again, like a lot of things, the evidence is quite a bit stronger in HEF-REF. Um, Mildly reduced ejection fraction as well, but if people have a true HEF-PEF with ejection fraction of 60, there doesn't seem to be as much benefit for replacing iron. Uh, the cutoffs are reasonably high, so a ferritin under 100, so often we wouldn't worry too much about a ferritin of 90, or in fact, even a ferritin up to 300, depending on transferrin saturation. So um, there seems to be benefit, even if people are not super iron deficient by our normal uh, definitions. The main benefit in this seems to be symptomatic. The studies have not really been able to show a very strong survival benefit, but certainly a quality of life and exercise tolerance benefit. So I've whizzed through that reasonably quickly. Um, that was all HEF-REF. And as I mentioned, that's sort of the mainly the more recent things. Um, Everything else. So these guidelines I've been talking about really are interesting in that in HFpEF, we don't have anywhere near as much. I'll go into a little bit. Diuretics help whatever heart failure you've got. They're class 1 recommendations, and generally we mean loop diuretics. We now have enough evidence now to say that SGLT2 inhibitors help really across all ejection fractions. But that's about it for HFpEF, apart from clarifying what the etiology is, because there are some cases where a particular targeted treatment might help. HEF with heart failure with mildly reduced ejection fraction, as I mentioned, it's a bit of a grey zone, and that's why these Class B recommendations are there for pretty much all the other 4 pillars, because some people do benefit, and it's probably because there's this overlap. It's a spectrum, but also if you do an echo on someone and they're in this range, it may well be that as it's a dynamic thing, you maybe just be catching them, and maybe if you repeat it in a year, they're actually on their way to being HEF-REF. And so that's why I think we do need to individualize things a bit and accept that we don't always have clear evidence for what medication is going to work for the patient. This is the same equivalent thing for the American guidelines. Their pictures are a bit uglier. Interestingly, they are less confident in other things in HEF-PEF, but really it's the same thing. I've put this up. This is a recent-ish SGLT2 inhibitor meta-analysis, and really showing that across all the types, across all the trials, it does seem to help combined endpoints and cardiovascular deaths quite significantly, but particularly across ejection fraction. So this is the sort of the thrust of this paper was looks very good in HEF-REF, looks reasonably good in HEF mildly reduced ejection fraction, and then even patients with an ejection fraction over 60. This is again a combined endpoint, but we can sort of, this is why we can prescribe these drugs really regardless of the ejection fraction. It is a different, to be nitpicky, it's a different authority, streamlined authority code when we're prescribing it. It's a long list now. There's CKD, diabetes, HFpEF, HFrEF. I'm going a little bit more into this 40 to 50% range, partly because I think it's interesting, and we often don't know what to do with these patients. And I remember sort of just thinking if the ejection fraction's above 40, there's not a lot apart from diuretics, but there actually is evidence that a lot of these drugs do benefit. So this is candesartan across the ejection fraction spectrum, and they've sort of plotted this as a treatment effect. So anything under this line technically is beneficial. And you can see that once it dips below really somewhere around, if we use the confidence interval, they've given this blue box here. So even up to 50, this 40 to 50 range, there certainly is benefit for, all they've got a trend here, but it does seem to have benefit well above 40 for some of these drugs. And this is for spironolactone, same thing. So the crossing point is actually more like 60%. And even up to 50 to 60, there is benefit in cardiovascular death and all-cause death. And beta blockers. So we tend to think beta blockers, I always sort of think of them as really, if the normal ejection fraction, certainly normal ejection fraction, they're not going to do much good. But it does seem that even if people have ejection fractions up to 40 to 50, this mildly reduced, they help. So I think these sort of somewhat more recent trials would sort of support the idea that our mid-range ejection fraction often behave a bit like reduced rather than preserved, keeping in mind that it's a very mixed heterogeneous group, and I think we're probably getting to the bottom of what makes up that group and better stratifying those patients. If we start doing MRIs on everyone or more workup, we might get more answers. But certainly once you get over 50, beta blockers really don't have a lot of benefit for heart failure. They might need beta blockers for their atrial fibrillation or something else, but for heart failure. So that's coming back to this, and that's why we have this sort of gray zone there for those mildly reduced ejection fraction patients. So I've put this in, and I may have gone through quite quickly, but that's okay, I think. Purely because there's a lot happening with semaglutide seemingly everywhere, and now people are giving semaglutide to people with HFpEF, with or without type 2 diabetes. This one group got 3 massive papers in the space of about 6 months in the New England Journal and Lancet. These few papers showed, unsurprisingly, that people lost weight and they were less short of breath with semaglutide. And then this is a pooled analysis of these showing that it prevented heart failure hospitalization. So I don't know how far we are away from giving people semaglutide for heart failure. The BMI cutoff of these were 30, so it wasn't a very high BMI by community standards, but it's sort of intuitive that this would help heart failure. I mean, there were reasonably big numbers of patients, but pretty tiny numbers of heart failure. So I think with a grain of salt, there was 8 patients that had heart failure in the treatment group and 30 in the placebo group. And another group had another drug of this class, again, EF of 50, BMI over 30, and they had to blow up the Kaplan-Meier curves, but it did reduce death from cardiovascular cause or heart failure. So again, one of these composite endpoints. But really, there's interest of these drugs across heart failure now. I thought it was worth mentioning, not so much. I mean, I made this comment before that African American patients seem to have different evidence in some of the big trials, but more probably relevant to us is the majority of the trials we talk about, and this is in all sorts of things, are excluding a lot of the patients that we see. So how many of our patients that we see with heart failure are over the age of 75 or even often over the age of 85? And we don't really have any trials in those patients because trials generally exclude them. But just more generally, I think the risk benefits considerations are different. And all I think we can do is individualize. It's a bit like if a 90-year-old really doesn't want to take their statin, there probably is still a benefit. Obviously, they're going to have less benefit than a younger person, but if there's risks to a medication like these ones, which can cause hypotension, I mean, relevant to heart failure, things like depression and some of these things, luckily for us, financial toxicity is an interesting term they use in America, but luckily for us, that's not as big a deal, but it can be. So we do need to individualize. And as I was making that comment before, that if I have an elderly patient in their 80s with heart failure, I'm not going to be so obsessively getting their beta blockers up to maximum dose and their Entresto up to maximum dose if there's any sort of hint of presyncope when they stand up or if their potassium's getting up to 6 and that sort of thing. And frailty in general, I think frailty is something that we don't think about enough, and that's another big growing field of trying to assess what degree of frailty makes some of these medications more harmful than beneficial. What have I got there? So just talking about HFpEF a little bit, one of the reasons why HFpEF is, I think, a very mixed bag, it's probably at least 50% of heart failure. That's partly because of our population aging, and we're probably getting better at treating people's blocked LADs and things. So the patients with very low ejection fraction and chronic heart failure, we've got a lot of drugs for those people now. HFpEF we haven't, and the sort of stereotype of elderly patients with hypertension and valvular heart disease getting diastolic dysfunction is a huge part of cardiology, but just medicine in general these days. Um, and there's been a real explosion in awareness and options for amyloidosis. So I'll acknowledge I'm biased in this. I work in the amyloid clinic in Westmead, but it's probably way more common than we thought, particularly transthyretin amyloidosis, which is the more common. Transthyretin is a protein made in the liver. It transports thyroid hormone and retin or vitamin A around the body. And for some reason, in some elderly patients, particularly men, it starts to fold abnormally into amyloid. And it's not rare. So there's some studies suggesting probably somewhere 10 to 15% of unselected heart HFpEF patients have positive bone scans. Um, there's an association with TAVI and aortic stenosis. So, sorry, not with TAVI, with aortic stenosis. And there's been a few studies now scanning people who are undergoing TAVI, and it's sort of that same number, 16% or so. And that's a pretty big number when we now have disease modifying and prognosis modifying drugs, which we don't have a lot of in HFpEF even today. And there's a lot coming down the pipeline in the next 5 to 10 years, treatments in this condition. So I think part of it is awareness to think about. I'm still not even clear myself how many people we should be screening. Should I be sending everyone with HFpEF for a bone scan? Maybe not, because that's a whole lot of bone scans. But if they have any sort of red flag, then that would be a reason to think of that. Talking about red flags, being over the age of 60, having aortic stenosis. Interestingly, this list from the Australian consensus statement didn't mention being male, but that is, I mean, I guess maybe it's not a red flag, but it does make it more likely. And interestingly, there's some strong associations with carpal tunnel syndrome, particularly bilateral carpal tunnel syndrome, and lumbar spinal canal stenosis. Often these things manifest 10 years before they're diagnosed with cardiac amyloid. And there's an interesting spontaneous biceps tendon rupture is really quite strongly associated. So that would be something where if someone says, oh yeah, that happened just out of the blue, they've actually got a pretty good chance of having cardiac amyloid. It's a funny thing though, people often don't notice it. I had a patient in an amyloid clinic who just said, oh, by the way, I noticed this funny lump in my arm, and he had the classic sort of Popeye sign of a ruptured biceps tendon, and hadn't even mentioned it to someone before. Uh, when we look for cardiac amyloid, ATTR amyloid, we generally as first line, obviously an echocardiogram, and we probably shouldn't be doing these further tests unless someone has characteristic echoes, so thickened walls in their myocardium, left ventricular hypertrophy sort of picture. But the most accurate test really for screening is this nuclear medicine test, which is pyrophosphate scintigraphy, which is a bone scan basically. We often call it cardiac scintigraphy to make it a bit less funny sounding when you talk about bone scans, but you can see in this visual grading, it really does light up in these patients. There are some false positives and false negatives, so it's often not a clear diagnosis, part of the reason why specialized clinics can be of use. But if you think of it and you do the scan, often you pick things up and just showing that when you get SPECT imaging, which is luckily becoming standard, I've done quite a few of these scans out in Bathurst and picked up a few, but also a lot of negative scans, so I'm obviously biased. But you really do see it localizing in the myocardium on SPECT imaging. And the reason I'm going on a bit about it is we have tafamidis now, which is now in the PBS, and 30% reduction in all-cause mortality is pretty impressive in HFpEF. This was the landmark trial. It's now 7 years old. Some of the more recent trials haven't quite gotten this. I think they selected this patient population quite well. It might be that just patients are getting diagnosed earlier, and the more recent studies seem to show that survival is not this bad. This type of cardiac amyloid, as opposed to AL or light chain, it's not as dire a diagnosis. As you can see, I mean, this is out to 2 years. Even with placebo, 70% were alive. So not great, but light chain amyloidosis, which is somewhat related to myeloma, has an abysmal prognosis when it involves the heart, and often patients walk in having looked up a median survival of 6 months or that sort of thing. So this is not that sort of condition, but we now have This medication, tafamidis, is a anti-inflammatory actually that acts as a stabilizer. It doesn't remove what's there in the heart, but it stabilizes the tetramer to stop it misfolding, which is our stabilizers here. Um, Tafamidis and acoramidis are similar class. Uh, we are involved currently in a CRISPR gene editing trial and a depleting antibody trial. So these trials are in advanced clinical trial stage. We have some of these RNA silencers, patisiran and vutrisiran, are on the PBS for people that have amyloid neuropathy, not yet for cardiomyopathy. So these are quite promising drugs. The CRISPR gene editing seems to just switch off the CRISPR gene, and their levels just go down to zero, basically. So that's a reason to think about this condition. Obviously, they should have heart failure and they should have a typical echo, but it's just something to be aware of. And that's sort of stressing this. So increased wall thickness, red flags, like I spoke about. Some of them are clinical, like the carpal tunnel syndromes and biceps tendon rupture. Other things are they often have an ECG that doesn't match their hypertrophy. So usually someone with very thick left ventricle will have an abnormal ECG. At the extreme being people with hypertrophic cardiomyopathy have very dramatic ECG changes. Often these patients have a very thick heart on their echo, but their ECG looks pretty normal. We say inappropriate low voltage. And that's because the thickness isn't from muscle, it's just full of amyloid. So they don't really have thick. It's not even really hypertrophy, it's pseudo-hypertrophy. So instead of it being electrically active myocardium, it's just full of starchy amyloid, and so it doesn't affect the ECG. These patients often have a persistent troponin elevation, and often they're recurrently sent to hospital with this trop rise and diagnosed as non-STEMI, but their coronaries are normal. So I sort of almost think of recurrent non-STEMI as one of these red flags of having some sort of cardiomyopathy. Remember that troponin is not at all specific. PE can cause a troponin rise, any sort of cardiomyopathy, and that includes amyloid. Because I've mentioned it, I will mention that if we're particularly thinking of amyloid, I've really just talked about bone scans, which looks for ATTR. We really should do a monoclonal gammopathy screen, which includes a serum and urine EPG and IPG and a serum-free light chains. That's because that's a diagnosis you really don't want to miss. And like I said, people can deteriorate and die within 6 months if they have cardiac involvement. And it's often delayed diagnosis because it's very non-specific the way they present. And these patients, unfortunately, can also have a positive bone scan. So whenever you have a positive bone scan or a very suspicious echo, we really should be sending off that MGUS screen as well. But again, there's increasingly availability of more specialist centres for this. For a while there, it was just Westmead and Vinnie's. Canberra now has an amyloid clinic, I think, on their process of getting one. So there's a little bit more availability for some of this care. So I certainly haven't taken 90 minutes, but so we've spoken a bit about the classification of heart failure. Most of the progress really has been in HFrEF still. We've got our 4 pillars now, and with those 4 pillars, if we can get people up to big doses, we really do have quite impressive reduction in outcomes. And adding to that, our gradual sort of improvement in device therapy and maybe AF management. I think there's been a lot of improvement there. The mildly reduced ejection fraction seen is a bit less clear, although there probably is evidence. And I think if people's hypertension can tolerate it, they probably should be tried on some of these medications. I didn't mention that obviously if someone has HFpEF, we should treat things like hypertension with these drugs. So controlling their hypertension, controlling their comorbidities is often the most important thing. And then uh, thinking a bit more about etiology, and I think this is also a cardiologist side of things, rather than just saying this person's got a dilated cardiomyopathy. We probably are obliged to rule out ischemic versus non-ischemic, and then non-ischemic cardiomyopathy is again another one of these very vague buckets that we throw everyone in, but that can obviously be all sorts of things. So the amyloidosis sort of hypertrophic, subgroup, which might include HOCM, that sort of thing, and then the dilated cardiomyopathies, which more and more we're doing cardiac MRIs. which helps with cause, but also stratifying how much scar they've got, whether we think they're going to get VT and need a defibrillator. Um, and genetic testing is the other thing. Um, there's a few families around that have multiple family members with dilated cardiomyopathies that are inherited, and more we're using the genotype to risk stratify. So people are identifying some genotypes that um, have much higher risk of getting advanced heart failure needing transplant, and others that are quite arrhythmogenic, that get VT and VF arrests and need defibrillators, and others that are more benign. So the genetic side of things is progressing in quite a big way. And now that we have blood panels we can do, you can give people a pathology form to be done at Bathurst Hospital, and generally there's no out of pocket. I think that may have to come from a specialist, so otherwise it is thousands of dollars. But we can do genetic testing. Obviously, that can open up a can of worms, and really genetic testing should be done with a genetic counselor, or at least someone who's doing it right and explaining what we're testing for and what we're not testing for, and what sort of implications there might be when we do genetic testing. Okay, so that's actually the end of my didactic talk. I guess in terms of heart failure, um, I will just check again if people do have any questions about the non-pharmacological side of things. So um, all this stuff really needs to be individualized. Defibrillators have morbidity with them. The last thing you want to do is put a defibrillator in someone if they don't need it and they start getting inappropriate shocks, or if they get a device infection, it can be a disaster. So I always tell people if they need a pacemaker or defibrillators, it's not a big operation. You know, they can do it under local and go home same day just about. But anything has risks. So I think it's selecting patients um, who would benefit. And the same with CRT. I glossed over it a bit because even that's changing. The way we all learnt about CRT in med school was a biventricular pacemaker. These people get a second lead, or a third lead, a second ventricular lead to pace both ventricles, because conventional pacemakers are bad for the heart. You know, if you pace the right ventricle enough, you get worsening systolic function, basically. But increasingly, they're getting smarter with their pacemakers, and they're actually putting the leads right into the native conduction system. So we have His bundle pacing, which may promise to not need that second lead. You're just capturing the actual intrinsic His bundle, and avoiding all the problems, well, a lot of the problems of a conventional pacemaker. So that's sort of in a bit of flux, the CRT side of things. But the defibrillator side of things seems pretty stable, that if you've got a cardiomyopathy with an ejection fraction under 35, particularly if it's ischemic, and the patient has a overall life expectancy over 12 months or so, then it is beneficial to consider a defibrillator. Um, Atrial fibrillation, again, we all sort of remember from med school that with AF, rhythm control versus rate control, there's not a whole lot of difference. We just should, if you know, because all our antiarrhythmics have side effects, amiodarone, sotalol, that sort of thing, it's better for a lot of these patients just to control their rate and anticoagulate them. There was a big trial a few years ago called Castle HF trial, which was giving people AF ablations in heart failure. The idea being that now we have improving pulmonary vein isolation and procedural treatment of AF, that if someone has HFrEF, keeping them in sinus rhythm did really seem to help, particularly symptoms, but also maybe outcomes. That's been criticised a bit, that trial, or not criticised, but questioned, that maybe it was quite a selected population. So they're backing off a bit on that claim now. For a while there, it was everyone with HFrEF really should be sent for an ablation and try and get them back in sinus rhythm, and that it's intuitive that being in sinus rhythm is better than being in chronic AF. But that's another area which is in a bit of flux, with some, a bit of a push from the cardiology community to do a lot of ablations. But we need to remember that they have their risk, and in some patients, it's probably not really going to do much good. As well, this is, I guess, maybe not as super relevant if you're not the ones ordering them, but I don't talk a lot about cardiac MRIs. They have their role, and certainly overseas in North America and Europe, they're used a lot more. We're limited by availability and cost and very limited Medicare coverage. So for a long time, MRIs were really only available looking for ARVC, so arrhythmogenic cardiomyopathy. COVID sort of brought about a temporary item number for myocarditis, both for the drugs and COVID itself. That's been converted into an ongoing one. So finally, we actually have an MRI indication for myocarditis, which is crazy that we didn't have before, because you kind of need that to properly diagnose myocarditis. But what we don't really have an item number for is just generalized, heart failure, HFrEF or HFpEF, is this HOCM sort of thing, which are really key uses of MRI. Doing things by the book, there's going to be an out of pocket for the patient, that might be $600 or $700. So we don't use them, even in our amyloid clinic, we don't use them all that much if we can often get the answer with a good echo and other things like a bone scan. I think echoes can be hard, and I think if you're requesting echoes and you're getting a report that really doesn't answer your question, it's reasonable to try and get clarification on that. Does this show significant diastolic dysfunction? Does this show an explanation for why the patient's short of breath? Obviously, ideally, an echo can give you lots of information. It can tell you if the person's got severe pulmonary hypertension, but a lot of the time it doesn't. If you don't get a TR jet, which sometimes you just don't see, you can't estimate the pulmonary pressures. So echoes are very variable. Obviously, body habitus and all things aside as well. So not all echoes are equal, but it's probably an obligatory test. I think it's one of the more useful things you can do, obviously, if someone's short of breath. Obviously, I'm biased in that, but.
Well, look, thank you so much, Dr. Ginty, for a wonderful presentation, wonderful slide deck, great discussion. I have actually popped the evaluation for tonight in the link. I will just get another screen share just to pop the QR code up.
Well, stop sharing here.
So if everyone grab that from the chat box or put in from the QR code, we will also send these out post the session as well. And then in the chat box, another link for an optional post-measuring outcomes activity if you would like to claim an additional 1 hour within 30 days of the event. Okay, so just in closing, thank you everyone for joining us this evening. We really appreciate your time and your effort in being here. And once again, a huge thank you to our presenter, Dr. Paul Ginty. We look forward to seeing you all again soon, and good night.